And we are live.
Great. It's the top of the hour and I'm going to get us started. Well, welcome everybody. It's an incredible delight and honor to be here with you tonight for the second of our IAS-USA sponsored COVID conversations. I have the very good fortune of being here with my good friend Judy Currier. I'll introduce myself first and then ask Dr. Currier to introduce herself. I'm Dr. Jeanne Marrazzo, and I'm the Director of the Division of Infectious Diseases at the University of Alabama at Birmingham and a member of the volunteer board of the IAS-USA. And I have been never really considered myself a coronavirus specialist, but at this point, I think it's all hands on deck. So here we are. And Dr. Currier, did you just want to say hello? And I'll then move on to the moderator discussion.
Great, thanks, Jeannie. I'm Judy Currier. I'm the Chief of Infectious Diseases at UCLA and also the Chair of the AIDS Clinical Trials Group. And like Jeannie, have been gotten involved in COVID really over the last few months and learning as much as possible, and really excited to be here today to share some discussion on the topic of COVID in women.
Great, thanks, Judy. So let me just explain how these are going to go. First, I mentioned that this was the second of several planned conversations. The first one was with Drs. Paul Volberding and George Rutherford, and that happened a couple of weeks ago. That is available if you want to listen to it. I should note that the shelf life of COVID conversations is necessarily very short, as you probably know. As soon as we say something, there's new information that comes out practically the next day. So be aware that these will be available as recorded, but really unclear how relevant what we're saying will be in a month, for example. What we're going to do this hour is try to touch on some issues specific to COVID-19 infection in women. And Dr. Currier and I are going to have a conversation about this. I think I may have lost my, can you still hear me okay? Okay, yeah, I think I may have lost my headphones, my earphones. Let me keep going. So Dr. Currier and I are going to have a conversation about this topic for about 40 minutes, and then we're going to reserve 20 minutes for questions and answers. In order to ask us questions, you need to use the Q&A button. The chat is not functioning as it does normally during Zoom meetings, so please do that. And be sure that you ask us whatever questions you would like to ask. A reminder too that there is no CME available for this for the reasons that I mentioned before, namely that the content is so fresh and potentially so soon out of date that we really could not do that. So this is really for your own information. So I'm just going to start by giving us a very brief overview of where we are at with COVID-19 in the United States. And if you haven't been paying attention, this has been a really record-breaking week. Texas, Florida, and Arizona have all reported over 2,000 cases each in a single day. In Alabama, on Sunday, we had 1,000 cases. We're a pretty small state. Places that had things under control are now experiencing some resurgences, and that's happening globally too. Beijing has an outbreak right now that has actually forced them to shut down some travel. And the total number of cases that the United States has experienced is well over 2.1 million right now, and tragically over 117,000 people have lost their lives to COVID-19. And we'll talk a little bit about who has been most affected and how that's played out for women in particular. Yesterday in the United States, there were 25,000 new cases. And if you've been tracking the new cases in the US over time, that number has been pretty much around 20,000 for a while. There was a period in April, late May, where it was climbing down a little bit to around 18, but we're now moving back up. And yesterday, 769 new deaths. So really still a devastating toll. The other thing I would mention is that just in terms of the current situation, one of the reasons we think that all this is happening is that many states relaxed their both mask wearing requirements as well as their physical distancing and limitations on numbers of people who could assemble around the end of May and Memorial Day weekend. And the timing for this is perfect, right? Because we are seeing this wave of what happens in a weekend or that period, then going ahead and evidencing it as cases in 10 to 14 days, and then later, a little bit later, with hospitalizations and that sort of stuff. The only thing I'll say about the epidemiology is to point out that there was a really nice MMWR just yesterday that told us a good detail about the first 1 million cases that were reported to the CDC in the United States. These comprised cases from the end of January 22nd through May 30th. So really incredibly up-to-date information. In this database, again, these are reported cases to the CDC. The cumulative incidence, importantly for our topic, was similar in overall in men and women. And if you look at the risk factors for bad outcomes overall, and again, I'm going to ask Dr. Currier to comment on this specifically with women, it's really interesting. Cardiovascular disease, diabetes, and chronic lung disease really played out in the United States population as risk factors for infection. What I thought was really striking in this analysis is that people who had any of those underlying conditions were 6 times more likely to be hospitalized and 12 times more likely to die. So really staggering when you look at the profiles of people who have been dying of this infection. Interesting too, remember these are reported cases, so probably many of these people got tested because they were symptomatic, especially in those early months. But in this very, very large database, among the people in whom they had symptom information, which was about half, only 4% were asymptomatic. And most of the people who were asymptomatic had the really classic triad of fever, muscle aches, chills, and some headache. About 10% had disorders of taste or smell. So those are turning out to be really common. And as you know, that's a great specific screening question for your patients or patients you think might have it. And again, back to what we're talking about tonight, I was surprised to learn that among about the 64,000 people in this database who were women of reproductive age, 11% were pregnant. So there are data on 6,700 women in this database who were pregnant. So I'll look forward to a really detailed analysis of that, hopefully in the coming year. You know, again, I want to point out some limitations. Surveillance data do favor detection of more severe disease, more symptomatic disease. Probably not representative of the whole sort of pyramid base of who's infected, but I think it gives you a really good sense of what's been happening in the US until now. So Judy, I'm going to turn it over to you and ask you to take us into your understanding and perceptions of how these statistics and some of the other clinical aspects of COVID-19 we're seeing have played out specifically in women.
Thanks, Jeannie. Yeah, I feel like maybe the title of our conversation today should be all the things we don't know about COVID and women. And I think that, but why we should care and why we should pay attention to this as we move through this period of time. Because I think early on we had the sense that COVID was a disease that impacted men more than women, and obviously people who are older. But we're finding that, you know, I think that the importance of comorbidities as increasing the risk, I think are going to be really important to look at in the US. The sort of co-occurrence of epidemics of obesity and heart disease and lung disease may mitigate any beneficial or sex advantage that women would have to have a lower risk of acquiring the disease. So I think we're just really at the early stages of understanding this. I know here in Los Angeles County, where we are seeing 1,500 to 1,700 new cases a day, about half of the cases are women, 50%. And I don't know data on the outcomes, but by sex yet in any kind of detail, but I think the database like the one you just referred to and the MMWR and others will really help us to understand this. But it's clear that that obesity and hypertension, heart disease are key mediators of bad outcomes. And then the other issue is pregnant women. I think early on there was a sense that there didn't seem to be any excess risk of poor outcomes in pregnancy, but we know that pregnant women have a predilection for viral infections. Influenza is a perfect example where more severe disease is seen in pregnancy, and there really does need to be a major focus on getting more information about pregnant women. And fortunately, there have been some great efforts that have been put together very quickly, like so many things in COVID. A group of investigators at UCSF, Jessica Jacoby, Stephanie Gaw, Valerie Flannerman, and Yalda Afsham from UCLA put together a registry called Priority, which is following, it's basically the kind of registry where you can put your patient's information in there, and they're doing it kind of in real time online. They're tracking the outcomes of pregnant people who are COVID suspects, as well as confirmed COVID cases, and then the outcomes of their newborns. So I think this is going to be an incredibly rich source of information. And it's really important that the word get out that this is a registry that's available across the country, and hopefully people from all different settings will be able to take advantage of it, and we'll learn more about the outcomes of COVID in pregnant women.
Yeah, that's great. I think the pregnancy question is really interesting, and actually it's whoever just put those questions up there, it's perfect, because I was just going to get into some of the pregnancy data. So the best data, I think, and the best guidance, just so you all know about it, the NIH guidelines on COVID-19 have a nice section on management in pregnancy. Obviously, they're treatment guidelines, but they collate the information that the American College of OBGYN, as well as the Society for Maternal Fetal Medicine, have distributed, and especially the SMFM group has a fantastic document online that you can take a look at. The general sense, if you look at those guidelines, is that, sorry, I can't seem to turn my regular phone off here, is that there really hasn't been a good sense of adverse influenza-like outcomes in these women. Probably the best cohort is this Wuhan cohort, which was 147 women. All of them underwent C-section because it was before we knew anything about this. It was during the Wuhan outbreak. And what that allowed them to do, relevant to the question from Mana, was to test specifically for the presence of SARS-CoV-2, the COVID virus, right, in amniotic fluid, in breast milk, in cord blood, and in the neonatal nasopharynx. They did that for only 6 of these patients. They couldn't obviously do it for everybody, and they found it in none of those sites. There has been one report of a vaginal swab in pregnancy that has had COVID or SARS-CoV-2 detected. But what I think is interesting is that, you know, and Judy, I'd love your thoughts on this. There seems to be a very low rate of viremia overall with COVID-19 and with coronaviruses in general. And when you think about transplacental infection and intrauterine infection with the kind of things we worry about, the torch infections or herpes virus, you know, viremia, CMV, is a major player. So we aren't really seeing that in COVID-19, and that may turn out to be quite protective in terms of transplacental transmission. So
yeah,
any thoughts about
I think
that?
for viremia, it's a really important question. I don't think we know everything there is to know about this yet. And I think as people are developing more sensitive tests and assays, you know, potentially in later disease and more advanced disease, we may see viremia. So it may be true that it depends on the severity of the disease, whether there would be any risk. But you're right, so far it looks reassuring.
Yeah, it does. And I think the guidelines, again, from ACOG and MSFM really say that in terms of management of pregnant women, there should be the delivery should be made by obstetric indication. So no indication for C-section, no indication for early intervention. Again, it really depends on what's going on. The other thing I wanted to mention about that is the issue. Let me answer some of the questions first, and then I'll go down to my other points about pregnancy. And I want to ask you a question about one thing we might see in pregnancy. So I think transplacental transmission of antibodies and antibodies present in breast milk is a fantastic question. We haven't really even validated a great antibody test for use in people. I mean, we have a couple of good antibodies tests, and Judy, I'd love your thoughts about that. I am not aware that anybody has validated performance on breast milk or anything related to the female reproductive tract. So I would say that we don't know. We don't even know anything about generation of systemic IgM and IgG during pregnancy, and whether there's transplacental crossing. Judy, anything to add?
No, I know that people are collecting breast milk to try to look at this issue, but I don't know of any results of that yet either.
Okay. And then Gina asked if we know anything about ACE2 receptor expression in pregnancy. I do not know the answer to that. I can't think of a reason it should be different.
Yeah, no, I do know that there's some evidence that it's less in women, and that was one of the,
less in women overall.
Right,
yeah.
Generally women express it less, and that would be why the disease might be less common or potentially less severe, but I don't know whether it's modulated at all by pregnancy. It's a great question, Gina Brown.
It is. Thank you. I'm glad you're on, Gina Brown. So, hey, let's talk about specific therapies. So right now we have one product, right? Antiviral product that's has emergency use authorization for approval, and that's remdesivir. Have you used it to treat pregnant women?
Well, so remdesivir, I personally haven't used it, but I know it's been used in our hospital. Remdesivir, as you said, has this emergency use, and it was studied in the ACT-1 trial, which I have to say was really put together so quickly and enrolled so fast. It's really impressive to see clinical trials being able to be done in a pandemic and to be done so fast around the world, and to get answers, because that's really what we need to be able to understand treatment. And so pregnant women were not included in the trial, but they were included in compassionate use. And interestingly, in the rollout of remdesivir now through the distribution program, which has been a little spotty to getting off the ground, pregnant women are still able to get it now through the compassionate use. So to answer that question, I think just thinking about that trial, I looked at the trial for enrollment of women to see kind of how many women were included, and the study was 65% men. But they did look at outcomes by sex, and the recovery rate was the difference for women was also significant, and if anything, it looked like the recovery rate ratio was higher.
Right.
So there was no evidence that women didn't, that had more toxicity or a worse outcome, and it was nice to see that sex analysis in the primary report. I think more information certainly is needed, but it is available. Now, we heard yesterday about the results of the recovery study for dexamethasone.
But we kind of heard about them by press release.
Right, very preliminary.
So,
We've all learned we need to wait for the hopefully peer-reviewed manuscript to see what the the details of it. But it looks as if at least for people with advanced disease and serious illness, that appears to play a role, and it did reduce mortality, which is by the press release, which is something that remdesivir didn't show significant. It showed an improvement in mortality, but not statistically significant. So, I think that's promising as another potential adjunctive therapy.
Right. So it's interesting, the NIH guidelines, as well as the ACOG and MS Society for Maternal and Fetal Medicine. I can't get MSM off my mind. Sorry, it's my other job. It actually point out that none of the drugs that we've been talking about, including tocilizumab, azithromycin and hydrochloroquine, although we're a little bit less excited about those now, remdesivir and plasma, convalescent plasma, are necessarily contraindicated in pregnant women, nor are steroids. So, coming back to Carlos Del Rio's point here, and something that you and I have talked about a lot, there are really not a lot of reasons that these women should be excluded from these studies. I think it's a real problem, and not having these agents tested in pregnant women or breastfeeding women is really a big issue. So, I think it's good to know you can use at least the remdesivir for compassionate use.
Yeah, and well, it's sort of ironic. I mean, I know that clearly hydroxychloroquine did not fare well as a therapy for inpatient advanced disease and the population with high mortality, but it's certainly a drug that there's a lot of experience using in pregnancy and in women, and has a clear safety profile, but there's no evidence of benefit of that at this point. So I guess it's sort of a moot point, but we do need, I think the big point is that we do need to be able to include pregnant women in these studies. So convalescent plasma trials have included pregnant women, and I think will continue to, and as new therapeutic agents are rolled out, I think this is really important. I think we also need to focus more on, and this is just my own personal bias, but also on studies of people with mild disease to prevent hospitalization. This is a little bit trickier because the predicting who's at risk for progressing is not 100% clear, and so we want to treat those people who are at highest risk, and we need to get better at identifying them. And only, I think, through well-controlled studies will we learn what we need to know about that. But it's exciting to see monoclonal antibodies coming into the clinical research arena, and other novel, hopefully more antivirals, and hopefully we'll be able to get more data on those soon across the spectrum of disease.
So let me ask you, you asked me when we were talking about where to take this conversation, to comment on where the gaps are in trying to figure out how to treat women, or if we should think about treating women differently than men. And one thing that led me down this really interesting path was the whole sex hormone receptor issue with COVID pathology, and this question of whether androgen blockade in particular, so getting to the concept of why do men do worse, is it testosterone? Why do women do better? Is it because of a lack of testosterone, or is it because of estrogen? Apparently there are data, which I did not know before, that estrogen may actually help heal acute lung injury, which I wasn't aware of. But the Italians, in their experience in the Veneto region, did this really interesting analysis. A lot of patients looking at the outcome of mortality in patients with cancer. And as you would expect, cancer is not a good thing to have if you get SARS-CoV-2, and they had considerably increased mortality, except for the subset of men who had prostate cancer and were on androgen blockers, and they had a remarkably reduced risk of mortality. And in fact, there is now, I think, a study at UCSF that is being done to look at androgen blockade in severe SARS-CoV-2, and I don't know. It looks like Paul's on the line on the participant list. I don't know if people know anything about that, but it turns out that there is this. There's a protein that there's a membrane-bound enzyme that cleaves the SARS-CoV-2 spike protein, and it's actually in respiratory epithelium, and it actually is responsive to androgens, which I did not know. So there are people who are really interested, and also the people who are looking at drug libraries through computational models, I think have come up with a lot of hormone receptor modulation drugs that might be of interest. So when we think about that, it may be that something around the female hormone status, whether we'll find out that women who are on different hormonal contraceptives might have different courses, or whether that might be one of the reasons they're protected relative to men, will be really interesting.
Yeah, and I think, I know there are some other studies in development looking at this sort of axis of intervention, but the other group would be women who are taking estrogen blockers for other therapeutic reasons in breast cancer,
exactly,
for example. I think that's something that we need to keep an eye on as well.
Yeah. Yeah, I think that's a great question. The other thing that I was going to ask you about is this whole issue with hypercoagulability in antiphospholipid antibodies, and the fact that we clearly are seeing coagulation events, thromboembolic events in young people, lots of reports of stroke in young people. We know from some studies that, autopsy studies and others that have looked at the prevalence of DVT, people coming into the unit. I worry about that in pregnancy and the general hypercoagulable state in pregnancy. And I looked a little bit into that with the guidelines, and it's not recommended right now to do anything but prophylactic anticoagulation in pregnant women who are infected with COVID. But I do think it's something to think about, and people have thought about measuring D-dimers to intervene earlier. And I don't know if you've seen any more on that or know any more about that.
Yeah, no, I think it's really a fascinating area. I know there's a suite of trials that NHLBI is getting ready to launch, looking at different strategies for anticoagulation. And I think it's a kind of thing where places, all around the country, it's great that we have these guidelines that have come out to help in the absence of data from trials. But as people develop practices around different things, it makes it harder to do trials sometimes. So I think it's going to be really interesting to see how, with this changing landscape of the use of different anticoagulation strategies, we'll be able to really understand what works and what doesn't work. And again, it's all about, like, how do we predict who the people are that are going to have these more significant risk, and are there early biomarkers, like you say, D-dimer early in disease?
Right.
Somebody asked me the other day about they had a patient who they were testing for COVID, and the test came back negative, but they had an elevated D-dimer, and should they repeat the test? And I thought,
right.
well, why did you do the D-dimer? Right. And then I thought maybe they know something I don't know about, like
exactly. Yeah.
Of severe disease. But I think that people, really trying to understand this risk profile and the biomarkers that identify those at risk, so we can target our interventions a little bit more and not just try to give everybody everything.
Yeah, and that's a great point to remind, and I just want to remind people to keep putting the questions in. So we are going to save the last 20 minutes, and we will go back to those. So don't despair if we don't address your question right away. So just a reminder, Judy mentioned the ACT-1 study, which was the study that was published in New England Journal of remdesivir versus placebo in people with moderately severe to severe COVID-19 who were hospitalized. ACT-2, which is now over 60% enrolled, I believe, in global sites, so well over 700 people enrolled right now, has now randomizing people to remdesivir and versus remdesivir plus baricitinib. Baricitinib is a JK pathway inhibitor, so it's an immunomodulator. So the idea here is, as Judy says, you have at least an antiviral that has some effect. Can you add this immunomodulator on and really try to alter the course of disease? I guess one concern I have with that is that I agree with you. I'm not sure this one size fits all makes sense, because some people may need the immunomodulator, and it also may have to do with timing. You can't really do that in a randomized trial to start right off. But, I think if you're thinking about that immunomodulator having an effect in that third phase of the inflammatory storm portion of the illness, you would think you'd like to do it right as that was starting. So just a reminder, people are looking at this. And there's a bunch of other cytokine inhibitors that people are looking at in isolation, right? Without remdesivir.
Right, and I think as the studies have been done, remdesivir has kind of been weaving in and out, and so they'll all have to try to control for whether it was in combination or not. But we'll see. We're starting to, I think we're really, now at the point where studies that got started in March and April are going to start to report out, and we're going to have a lot more information. And I think it's important that we see that information broken down by sex where possible, and so that we can learn about this.
Mm-hmm. Absolutely. Let's see, what else did I want to ask you about this particular topic? We talked about the viremia. We talked about using, about general management in pregnancy. Did you have a sense, or do you, given your focus on cardiovascular disease and HIV, do you have any sense of why cardiovascular disease seems to be like the primary risk factor? And do you think that's going to turn out to be different for men or women? I mean, this is a very
Yeah,
hypothetical question.
it's a really, I mean, I think it's a really interesting question, and it's also hypertension, is really
Exactly.
specifically very, and I think everybody really focused early on and about, was there something about this, the ACE2 inhibitor and the ACE inhibitors, and was there this axis here? Does this explain it? But it just hasn't really really been clarified yet. So I don't know the answer to that, and I think it's fascinating. Women have different risks for cardiovascular disease over the lifespan, and I think that there may be that what I'm interested in seeing is whether women who have these comorbidities of obesity and hypertension have excess risk of COVID, independent of sex. Basically, does that make the risk basically mitigate any protective effect that being female might have had?
Right.
And I think we'll see more about that soon. I was thinking about the pregnant women. Another issue just for sort of clinical, and I'm not an obstetrician, but in the diagnosis in pregnant women, are they more likely to be diagnosed late? There's very common nasal congestion, with estrogen effects on sniffles, and shortness of breath can occur physiologically
Absolutely.
during pregnancy. So the symptoms might be a little bit missed, and I think without a high index of suspicion. And also, I think the willingness to come and get a test, or go, I think a lot of times just trying to stay away from other people and reduce your risk of exposure might just delay the time of diagnosis. So I think it's important that we really remain vigilant about trying to make the diagnosis early in that setting.
Yeah, absolutely. I agree with you for
I
sure.
wanted to ask you some questions.
Yes. Oh yeah, I guess I was asking you a lot of questions. I'm sorry.
No,
Sorry.
you've been doing a great job. I mean, I I do think that just the I guess we talked a little bit about the treatment guidelines that have come out, and just what's your sense about the just whether they've addressed the gaps in our understanding about treatment and women of reproductive age. I just feel like it's been pretty well covered in all the information that's out there. I mean, where should we be focusing our efforts here?
Well, I think one concern I have is that it's not, when we talk about women of reproductive age, right? Remember, many of the trials of new agents don't just require you not pregnant or breastfeeding, but you have to be on hormonal contraception so that you can't get pregnant. So when you look at those three things, it excludes a huge population of women. And as I'll talk about when we talk about vaccines, if you don't have a product for reproductive age women, you don't have a product for healthcare workers, given how many nurses are, in particular, reproductive age women, and how many physicians are reproductive age women. So I think we have a very big gap. I think the question is going to be, is this an opportunity to do something that the NIH has never done particularly well? And that's to rapidly perform bridging studies to get it into pregnant women, or women who are at risk for falling pregnant, as they say in Africa. The microbicide trial network, which was studying topical agents like tenofovir, also vaginal rings, had a very clear pathway for advancing products through, once it was shown to be working in women who fulfilled all the usual exclusion criteria, to then advance it into pregnancy, and starting in late pregnancy and then working your way backwards. I feel like this is our time to really force NIH and FDA in particular to sort of say, look, we have to accelerate the formal transition of getting these studies, not just compassionate use and a registry, but actually getting it FDA approved in pregnant and breastfeeding women, and women who aren't contracepting, who want to get pregnant. With the burden of this disease, this is not a rare disease. We should be able to do this. And I think that women would be very willing Of course, not everybody's going to be willing, but given the potential for bad outcomes, I think you would definitely be able to do it. So I think that's my concern. You know, we just don't know what this is going to look like. The one good thing about this is that, you know, we're looking at potentially brief periods of treatment, right? It's not like HIV where you're looking at lifelong suppressive therapy and you're worried about long-term, you know, embryogenic effects as women are pregnant throughout their lifespan variably over time. So I think it really should be a priority, and I have not heard very much about it, which I think needs to change.
Well, I mean, I think that the information can come from multiple sources, and there is a question in the chat of an abstract that's been submitted about the use of remdesivir from the
Yes,
compassionate use program in
thank
pregnant
you.
women, and I think that that is an excellent, you know, an excellent way to get information out. And I think the registries that are being put together, I think we need to gather data from many sources here to get it as quickly as we can, because I'm certainly agree that bridging studies are important, but being able to set those up in the right places that are going to, you know, have the patient population, I think using other sources of data collection that can get further, can be, you know, cover a broader area faster, or is also really important. And the compassionate use programs, I think, can also yield important data. It's great to see that being put together.
It is, but even that, it sounds like William Short mentioned that they fought a battle with IRB and we were able to include pregnant women. So again, I come back to this bias of, you know, even to use compassionate use, and you know, it's a bias, but I understand it's informed by caution, and it's not without sense, but it can be difficult to even get the kind of data you're talking about.
Yeah.
It's great that you have that.
Let's talk about prevention, because that is the other big, you know, thing that everybody's waiting for. I mean, we need, I feel we need both treatment and a vaccine, because even if we have a vaccine, it's not going to be everywhere immediately. So we need to kind of hit this from both sides. But as we think about the vaccine, and it's exciting to see so many vaccines coming into studies so quickly, and plans to evaluate them and manufacture them at the same time in case, you know, in case they work. But how are the vaccine studies going to deal with the issue of women of reproductive age and pregnant women? Are they going to be included, or how are they going to be evaluated?
Right. So my understanding, you know, as you probably know, there actually are, I think, like 160 vaccine candidates globally, if you really count up what people are doing at various stages. But there are the 5 companies and their candidates that are going forward as part of the U.S. effort. The vaccine that is closest to starting in clinical trials is the Moderna vaccine, which is the mRNA vaccine. And remember, it's just literally giving people the sequence that allows their cells to then create the antigen that will provoke antibodies to the spike protein in this case. The only candidate that I know, and so that's the first one, and that's supposed to enroll in a phase 3 study starting early July, and will enroll up to 30,000 people. There will not be any restriction on gender, so they will try to enroll men and women. Pregnant women will be excluded from that study, as will breastfeeding women. I do not know, I have not seen the protocol, whether women who are not actively contracepting will be allowed to enroll. I hope that they will not require that, because that means that women will get pregnant after getting the vaccine and can be followed forward. So they will have a registry for people who have gotten the study product, and they will follow them through for any events like pregnancy. So that will be a pregnancy registry, which I think is great. And it's probably, given your comments about how we need to work in the framework of what we can and can do from a regulatory standpoint, that's probably the best that we can do. So that's the only one that I know of, a protocol literally being almost ready to go, at least in close enough shape that it could start in early July. The other vaccine that is a close second, that is in later phase studies, I should mention, is the AstraZeneca Oxford vaccine. That's an adenovirus based vaccine that was used to, it's a chimp monkey model, and basically it's a modified adenovirus to elicit coronavirus antibodies. It's hard to imagine that that will be at all allowable in any kind of situation where women are probably not contracepting actively. If anything, I would think that that would be more of a concern. But we don't know yet. We haven't seen the protocol. We haven't seen the plan. So I think the best you can say is that women will get pregnant in these studies. And if you're having 30,000 people, you're going to see some pregnancies. Again, I come back to this concept, and I know I've told you this before. If we don't have a vaccine for reproductive age women, we don't have a vaccine for healthcare workers. So really, really critical to do that, given our risk.
Yeah, I think that's really important, and that's I think having this plan to be able to follow women who become pregnant on the study will at least yield some important data. The other sort of prevention modalities that are being discussed are post-exposure prophylaxis, either with convalescent plasma, I think a hyperimmune IVIG, hopefully a preparation that could be given IM will be on the landscape. And then again, the monoclonal antibodies are also being discussed as potential prevention modalities after exposure. And so that, I think there's less of a concern there for, well, we'll see, but you know, hopefully those studies are going to have to be pretty large, but hopefully they'll make the appropriate accommodations.
Yeah. Well, I think that we are amazingly, I know we could probably talk about this for a really long period of time because I just keep coming up with questions, and I should ask if you have any more for me, since I did ask you more than you asked me.
We can look at the questions that are on the chat here.
Let's do that. So this question, the first question, and a couple of people have asked this, what about blood group type being protective? And what do you think about that? Do you know anything about that?
I just don't know the answer to that. I've seen a little bit of the data, and you know, it's interesting in terms of what it might mean about the pathogenesis of the disease, but I guess it's not something we can do anything about in terms of modifying it. Not a modifiable risk factor, but I think it's fascinating, and I really look forward to having better understanding of it. I just don't know.
Yeah, I was thinking about it. I mean, a lot of this data, I just want to come back to this preprint. Again, so one of the casualties of the COVID era has been a real, I would say, threat to the integrity of the scientific publication process, not only because, you know, we're seeing so many preprints and people are taking the preprints pretty seriously. Remember, preprints are not, well, preprints are peer reviewed, right?
Preprint isn't really the right word, though, right?
No, it's the
material.
medRxiv, medRxiv thing. The thing I can't. So it's the pre-peer review material that's coming out, and the press release data that's coming out. I mean, I really can't let it pass that both the Lancet and the New England Journal published gigantic studies that were based on probably fabricated data. Again, I don't know that we know that yet, but the Surgisphere data. Anyway, and so I would just say again, I think as a reminder to look at all these reports with great caution, and I'm not aware of a really rigorously done peer-reviewed study that looked at this blood group question yet. I could be wrong. So I do not know, and I can't say anything more intelligent than that.
Well, there's a great question here about differences in pre and postmenopausal women. And there may be data there that has really broken down the risk by age within the female population. I think what's hard is making sure that we control also for the prevalence of the comorbidities that may also be impacting. So holding those steady, does it being postmenopausal increase your risk? You might think that it would, since older age does, but specifically the contribution of that compared to the other things, we just don't know. I think it's a great question.
Yeah, I do too. I want to sort of just mention that the blood type, somebody else mentioned this, the blood type that was linked to possible bad outcomes in the Wuhan data was A positive. And yes, Christine Brennan notes that the New York data attempted to sample, to adjust for this and looked at type O being, of course, as you would expect, the opposite and maybe not associated with better outcomes. But again, I just don't think we really know. Want to, I think that we covered this issue from Dr. Adepoju about evidence of maternal fetal transmission during pregnancy. You know, there is one case from the Canadian Medical Association Journal that is a possible true transmission event, I think. But even the authors in the title said possible transmission, perinatal transmission of SARS-CoV-2. They did a very nice job, I think, of looking for the presence of the virus by PCR as well as antibodies in all the right times. So, but I think that's probably the exception that proves the rule. So I think it's very uncommon based on what we've been seeing.
I have a question for you. Actually, this is really interested me as to whether during the COVID quarantine part of the pandemic and where everybody's been sheltering in place, have we seen a reduction in sexually transmitted infections in different communities in women and men during COVID isolation?
Yeah, I think it's a fantastic question. I'm also waiting for the COVID baby boom, right? Which I can't believe people aren't talking more about, probably next Christmas. I don't know, because I mean, this is a fascinating question. And, you know, if I had thought about this about 2 months ago, when I was not overwhelmed with COVID panic and anxiety, I would have like done a mail out self-collection swab thing and done it every month over the course of this, because my sense is that clearly people might be having more sex in isolation, but they're probably having more sex with people that they usually have sex with as opposed to new partners. I can't believe you got me to talk about STDs and the COVID talk. My goodness gracious. But my sense is that the network, the opportunities for sexual mixing in networks has been dramatic. I mean, people will always find a way, of course, you know, our patients always find a way. But I think that the opportunities for mixing were probably greatly reduced. So I suspect, but that might be offset by the fact that people weren't getting diagnosed. So all the clinics were closed. Our STD clinic here is still closed, probably won't open until August. Largely because they can't get PPE and the health department is so overwhelmed with COVID that they just can't get it together. So could be a combination of, you know, I'm worried about the boom now that people are going out there and, you know, no longer practicing physical distance and in the setting of not having adequate diagnostic infrastructure and care. So it could be a real thing. We'll have to see.
Yeah, another great question that was raised here is, what do we know anything about transgender women and COVID risk and outcomes? And I have not seen anything about that. I think it's a really interesting question and one that we need to pay attention to.
It's a great question, especially given the testosterone question. So for, you know, for trans men, is that going to be a risk? And that's a fantastic question. Those granular data are not in this CDC summary. Somebody also asked a great question, if I could just address it now, also about specific risk factors in pregnant women, I think. Were you seeing the same sorts of comorbidities that we were seeing overall? So there you go. Any data, Dorcas Baker, thanks. Any data on pregnant women with comorbidities such as coronary vascular disease, diabetes, or obesity? Obesity is a great question. I think we probably will see that. And if we look at gestational weight, that might be an issue. I would guess that with those several thousand people who are pregnant in this data set, we might be able to look at that because it had data on comorbidity. So look forward to that coming out of CDC.
Yeah, and then also just another plug for the priority registry. They have 800 people enrolled. I think 500 are pregnant women. And I think they're going to be looking at these issues really closely. So look forward to seeing their data when it comes out about both patient-reported outcomes and presence of symptoms, and then also, you know, how people do.
Right. So many great questions. Judy, you want to pick another one? Wow.
Just to highlight, we were talking about the level of evidence about the blood type, and Dr. Landovitz reminding us that the New England Journal published a GWAS study that showed an association in an Italian group, a cohort with blood groups. So there I think are some good data. So that's
And for
really
those
cool.
of you who don't know, those are genome-wide association studies. So again, interpret with caution, but that's my clever comment about that. Do you know of a commercially available quantitative PCR for SARS-CoV-2? I do not. Most of the labs I know who have done that and have looked, and what they've used it to look for, obviously, is the quantitative changes relative to time, and also comparative performance of different diagnostic tests. But that's been an in-house thing, so I do not know.
I know people are developing them for research use, but I don't know of a quantitative one that's commercially available.
Yeah. Lots of comments about rebound to STI spikes, right? Surveillance. I mean, who's doing STI surveillance right now? We can't even do COVID surveillance. So great point. There were a couple of other interesting questions. Any reason to think that pregnant women might have potential risk of shedding replication competent virus for longer periods after symptom onset? Let's just talk about that. Remember, and Judy, I would love to hear your thoughts about that. The longest people, my understanding that culturable replication competent virus has been detected in that early phase of illness was about 9 to 10 days. So after that, everything appears to just be by nucleic acid amplification technology, or PCR, and it has assumed to be non-infectious. I don't think anybody's been shown to be infected by somebody with just that type of shedding. So I don't know the data for pregnant women. I would guess that if they do have prolonged shedding, they would not be shedding replication competent virus, but I don't know.
Yeah, this positive PCR, and what does that mean? And is it really shedding, or is it just dead virus? It's so important because some people do have continued symptoms of fatigue, and then they get tested again and it's still positive, and they don't know what that means. And so I think being able to have other assays that would give us more sense of whether it's an active infection or not would be important. But it seems to be fairly prevalent that you can continue to shed for a while. And
yeah.
It can be very hard when people are trying to get out of the hospital. Or
I was on a call with several people with IDSA division chiefs last Friday, and Lizanne Porofsky from Mount Sinai was on, and she, obviously they've seen a ton of patients, and she noted that in the studies that they have looked at, where they have prospectively followed people with quantitative PCR, looking at the viral burden in the lung, she basically said that the amount of antigen in the lungs over the course of weeks after infection is just staggering. And so people have a crap load of virus in their lungs. And if you've seen some of the lungs on the CT scans or in the autopsies, it's not surprising. So in other words, I think it takes a long time probably to get rid of that dead virus, assuming it's dead. What do you think about women with HIV and COVID-19, Dr. Currier?
Yeah, well, I think HIV and COVID just in itself is a topic for a webinar, another conversation. Really looking forward to seeing more data on this. I think anecdotally and completely just not based on any sort of controlled information. It doesn't, we really braced ourselves in the beginning thinking that this could be a really bad, we'd see an upsurge in people living with HIV, and it just doesn't seem, talking to people around the world, that we're seeing that. And so understanding why that is and whether it's the same for women and men, it should be high on our radar. And I just keep expecting every week for some big series to come out from Europe that's really looking at the outcomes for people living with HIV. But
yeah, I'm sorry, go ahead.
No,
yeah. I think one thing that we don't have a huge amount of time, but I just want to say that I think that I'm really worried about the long-term pulmonary and cardiovascular effects, especially in older people and obese people, people with hypertension and diabetes. Because if you look at the pathophysiology of these microthrombotic events and you think about pulmonary hypertension in the lungs and the damage that you can see in the lungs between not just the viral infection, but then also maybe pulmonary hypertension from clotting. And I think that really needs to be carefully looked at. And I worry about that specifically in HIV, given the long-term kind of hyperinflammatory intravascular syndromes that we know occur. So I think it'd be a fantastic thing that we need to study and really understand.
Yeah, no, I think that's a really good point that when it does occur, will the sequelae be more severe or more long lasting? It's really, really important point. Well, it looks like we're almost out of time here. I feel like, you know, this conversation is more questions than answers, but I think highlights some of the areas where hopefully we will get more information and maybe we'll be able to come back again in a few months and share some of that. I just feel like it's so hard to keep up with everything that's going on and you know, just finding the time to read and understand it and digest it. And so it's helpful just to be able to talk about it with other people. And I hope that this conversation has been of some value to those of you who are out there listening today.
Yeah, me too. One good question that maybe we can answer is somebody asked if you had a source for CAB members to share with their communities about the latest COVID news. Maybe we could just end with that because again, there's a lot of misinformation about COVID and trusted sources. Any thoughts on your side, Judy, that you have used and really think could be valuable?
I mean, I still go to the CDC website to get information on COVID. I feel like they have a lot of really great information that is digestible and easy to, you know, help, can be explained and can be shared with people. So I really continue to use that as a trusted source of information.
Mm-hmm.
That's the one that comes to mind first.
Yeah. Yeah, I think it's really good. The IDSA website has some very nice resources too. That's idsociety.org. They have a nice kind of resource area. And then there's some really great graphs. The Washington Post in particular has some very nice visuals and they're free. So very important. You don't have to get behind a paid firewall, unlike some other publications. All right. Well, we should probably stop. I apologize that we did not get to all the questions, and many of the questions probably we would not have had definitive answers for anyway, because as you noticed, a lot of what we said was that we just don't know. But I think it's really good to raise the questions, and hopefully we can come back in a few months and revisit some of these issues. I really want to thank Judy for agreeing to do this. And I want to thank Jose Francisco, who is our technical person, and of course, Donna Jacobson, who got us together for all this. I really hope you'll join us for the upcoming conversations. The next one is very special, a sibling conversation, right? On July 22nd with COVID-19 updates from the IAS conference. And then the week after, Mike Sag and Chip Schooley will be giving you some updates. Because this is a brand new effort, we really, really would love your feedback. So was this helpful? Did you like the format? We didn't want to do slides. We think everybody's, of course, totally slided out. So just let us know what you would like, and if there are topics too that you would like to see us address. And that is the way that you can contact us. And I believe the last slide, if I'm not mistaken, is just a slide announcing our upcoming webinars. Yes, there you go. Judy, did you want to say anything else?
No, I wanted to thank you, Jeannie, for doing this and everybody for listening in today. I just feel like we're all, not only are we all in this together, we're all learning about this together, and just so valuable to hear from our colleagues and learn together as we work to try to really end this pandemic.
Yeah.
We've got a ways to go, but I think that you know, I think that we can do it. It's just going to be tough.
Yeah, and we really need to do it together. And it's so helpful to know what your questions are, because there were several questions here that really got me thinking. And again, it's a collective effort to try to understand everything. So thank you very much.
Thank you.
Bye.
Bye.